Thank you so much for keeping this session. It was initially, I don't know how, removed and then again put back. So, selection of first line therapy for exon 20 insertion. We are all familiar that uncommon EGFR mutations do need a specific kind of a treatment depending on what the EGFR mutation is. So this is the retrospective analysis of patients who were treated in Tata Memorial Hospital, and out of 5,738 patients who were tested for EGFR, out of 1260, 83 patients had uncommon EGFR mutations, coming to an incidence of 6.58%. Amongst these, exon 20 insertion were 19.3%, the third most common mutation overall. So what happens when there is an EGFR exon 20 insertion? So there is a C helix, which is a regulatory domain of EGFR receptor, and it pivots from an outward inactive conformation to an inward active conformation, which remains active without any ligand binding. So these mutations are not sensitive to the usual EGFR stimulation that happens, and also do not respond to the TKIs. Overall, like I said, these are the third most common EGFR mutations occurring in less than 5% of NSCLC patients and 4 to 12% of patients with EGFR mutations. The most common exon 20 insertions are insertion ASV, insertion SVD, followed by insertion NPH. So it is preferable to do an NGS, and many a times PCR-based assays may miss exon 20 insertion. So if you have a female patient who is an adenocarcinoma histology and the smaller panel or a non-NGS panel has not picked up a mutation, so I would recommend to go ahead and do an NGS. It may sometimes pick up an exon 20 insertion mutation. Across all literatures, low response rate to TKIs up to 13% of overall response rate with second line treatments as well, with a median PFS for 3.5 months. So there was preclinical in vitro evidence that there is some activity of osimertinib against EGFR exon 20 insertion, a bit with a weaker potency as compared to afatinib. However, the evidence to support osimertinib as a candidate in the inhibitor for exon 20 insertion in vivo still remains unclear. And since all these papers of uncommon mutations, exon 20 is a subset and the numbers are very, very less to comment upon. So even in our paper, majority of the patients received chemotherapy and only less than 50% received osimertinib. In phase 2 clinical trial, osimertinib is being tested for this specific exon 20 cohort, and this study is currently ongoing. So as per the guidelines, the first line treatment for these patients is systemic chemotherapy depending on the histology. So in the paper that I mentioned, the retrospective analysis, the median PFS of the exon 20 insertion was 6 months and the overall survival was 15.8 months. So what next after chemotherapy? Do we have any other agent which specifically can combat the effect of exon 20 insertion on the tumor cells? So amivantamab in exon 20 insertion, the Chrysalis phase 1 study did give a molecule which is fully human and a bispecific antibody which inhibits both EGFR as well as MET, with immune cell directing activity designed to engage these two drivers which are very specific in the NSCLC. What it does is, by binding to the extracellular domain, it inhibits the ligand binding and it promotes receptor activity complex endocytosis and degradation, and results in an antibody directed cellular cytotoxicity. So we have discussed this study in detail in Dr. Vijay Patil's talk, and it is definitely a promising molecule. In the second line setting, the overall response rate was 40%, a clinical benefit rate which was a stable disease at least 11 weeks, or a response was up as high as 74%. Median duration of response was 11.1 months, with a median PFS of 8.3 and median OS of 23 months. So very respectable results. And this is how we knew that it is going to affect all subgroups of patients. So on an average, the overall response rate was 40% or more across all cohorts. It is a difficult drug to administer and manage. Grade 3 adverse events were seen in up to 35% of patients, and 30% did have serious adverse events. So it has both the toxicities of EGFR agent as well as MET pathway inhibition. Most common are the rash, infusion-related reactions, paronychia, hypoalbuminemia, peripheral edema, and GI toxicity. But like we have improved post chrysalis, now we know that we give the first dose in a split manner, and now the infusion related reactions are very, very few in the patients which are being treated with this molecule. Another new drug on the block for exon 20 insertion is mobocertinib, which is an oral TKI. Again, the approval as of now is in the second line with a response rate of up to 30% and a duration of response of 17.5 months. It is also a toxic drug, and 46% of patients did have significant toxicity in the phase 2 study. So what next after chemotherapy? This is the only paper which has shown some promise of immunotherapy with combination of chemotherapy in this cohort of patients who are EGFR mutation positive. So the atezolizumab, bevacizumab, paclitaxel, carboplatin, median OS was not reached in this arm versus 18.7 months in the chemotherapy plus bevacizumab arm. Also for the EGFR mutated patients, the overall survival was statistically significant, and it was seen that the patients who had received previous TKI also derived benefit. So if you see, the placement of both the new drugs as of now is in the second line, but can we push them early? So this is the PAPILLON study which is currently ongoing, where pemetrexed plus carboplatin is being given along with amivantamab as compared with the pemetrexed carboplatin in these patients who are exon 20 insertion mutated. And definitely the placement of this drug is going to come in the first line setting. So to summarize, the preferred first line treatment for exon 20 insertion as of now remains chemotherapy. You can choose the backbone of chemotherapy depending on the histology. Since majority of the patients are adenocarcinoma, pemetrexed carboplatin is the good option. To approve targeted therapies for these patients, neither of them is approved in the frontline setting. Role of immunotherapy for these patients is still an open question about whether we should be giving them first-line chemotherapy plus immunotherapy combinations, or whether perhaps these patients may have less benefit from immunotherapy, because this is a subgroup analysis, the IM Power 150 study. And what is the role of sequencing mobocertinib and amivantamab? Can amivantamab be sequenced? Can mobocertinib be given after the patient has received amivantamab? That is still a question. So thank you so much.
Thank you very much, Dr. Shruti, for a wonderful talk on a rare but neglected topic. Now, house is open for questions. So there is no query. So now